Hello, everyone, and welcome to Psychiatric Mental Health 1. This is adults. I'm Dr. Spencer. I'm going to be your instructor for this course. This week, we're going to be looking at theoretical review and foundations of psychopharmacology. Now, most of you just got done, or all of you just got done with psychopharm, so this should be a nice little review for you. Our assignments this week, you'll have a journal reflection on what happened to you. In your Toussaint and Fitzpatrick book, you'll read chapters 1, 2, 4, and 7, and review chapters 3, 4, and 6. And then there's also a discussion board on the TED Talk, I Am Not Sick. So we're going to be talking a little bit about theory. So what is theory? Well, it's a way to understand the world and describe or explain, predict, or control phenomena. Um, the practice of psychiatric mental health nursing is guided by theoretical understandings. These include grand theories, middle range theories, micro level theories, and they're a foundation of practice for the advanced practice nurse. And as you see here, theory is the underpinning of all that we do. So there are several types of theories. It's quite a bit, and you all probably know a lot of them. You have your psychodynamic theory, which was authored by Sigmund Freud, and then continued on by two of his students, that was Carl Jung and Alfred Adler. And they embraced Freud's findings regarding the conscious and unconscious mental processes and how they influence behavior. And then you have cognitive theories such as Bandura and Beck, that thoughts guide behavior. Very, very interesting theory. Then you also have behavioral theory with Pavlov, who surmised that there was a direct connection between thought processes and psychological responses. And you have developmental theory by Erickson, one of my favorites. Um, and it's a common in nursing to use Erickson. And he shared stages on development. Um, and then you have your humanistic theory by Rogers and Maslow. That's a hierarchy of needs. Rogers is unconditional positive regard. And then you have your biological theory, and then the change theory by Prochaska and D. Clementi. And you'll see the change theory used a lot, the trans-theoretical model, um, used a lot in nursing and psych nursing and in substance use disorder treatment um, as well. So we want to look at some of the our fathers and mothers of psychiatry. Henry Stack Sullivan was an American psychiatrist and a psychoanalyst who developed the interpersonal theory of psychiatry, which focused on relationships between people and the dynamics of personality. He was a major contributor to the field of psychiatry and psychoanalysis and anthropology, and is considered one of the most influential psychiatrists of the 20th century. And his theories and methods were widely adopted by other psychiatrists and psychologists. And then Hildegard Peplau was an American nurse known as the mother of psychiatric nursing, and she's credited with introducing the term interpersonal relations to the nursing profession, and is best known for her pioneering work in psychiatric nursing, which she began in the 1940s. Her theories and research focused on the nurse patient relationship, and she's credited with developing the concept of the therapeutic nurse patient relationship. And her theory on interpersonal relations moves from orientation, identification, exploitation to resolution. So, why do we study theory? I know some of it seems silly, but some of it is relevant and applicable to situations where you're working with others. So, theory is kind of the underpinning of all that we do, and it provides an aha phenomenon for when you're working with someone or researching things. It weaves consistency into our practice, and it may provide an explanation as to why we do what we do. So there's theory, research, evidence-based practice. So theory can guide research, or research can guide theory. Evidence-based practice equals research plus real-life clinical experience. Very important to know that. So in summary, if you want to practice holistic and integrative care, you must effectively integrate theory, research, and evidence-based practice into your practice and what you do when you care for others. So we're going to look a little bit now, chapter 2 in Toucey and Fitzpatrick, shared decision making. Again, some important defining terms here. We're looking at concordance. It's a process of developing a mutually agreed upon treatment plan with the patient. You're working with them. Compliance, that's an act of following instructions. Adherence, it's a process of sticking with a course of treatment. And so you want to work in partnership with your clients. I always try to tell my patient, I'm here for you. We have to work together. The client is the expert in their symptoms and life experiences, and you, as the psych provider, PMHMP, are the expert in your knowledge and clinical expertise. So when you have uneven partnerships, um, you don't develop good therapeutic alignment and can run into difficulties. And a lot of times, clients won't come back or they won't adhere to their medication. So you have to respect that we are all in an unintentional position of authority, whether we like it or not. But how do you work in partnership with certain situations? So, say a patient is non-voluntary and they're detained, they're legally incompetent, etc. Well, how do you work with them? Or a patient is cognitively impaired. So, it's important to find ways within those dynamics to work with patients, to partner with them as best as you can, given the limitations of what you may have to work with. And there's this health belief model, which was developed by Maryland and Cash in 2005. And it attempted to understand a medication taking behavior in mainstream psychiatry by analyzing how people interacted with it. They identified three broad types of medicine taking behavior. Um, and the clinical utility of this for us is to recognize which type of behavior people exhibit in order to tailor further intervention accordingly. So you have your differential compliant type, and this is the person who defers to the prescriber all the time. Generally takes their meds no matter what. So they will say, yep, whatever you say, I'll take it. Then you have your direct reaction type, um, or direct reactive type. I'm sorry. They stop their medication, um, and they deny the need for medicines and ceases to take their medications. Um, and then you have your active discernment and optimizing type, and this includes some cohorts of people with the ability and will to reflect on past experiences. And they're divided into two subtypes. So you have your experimental, and these people are reflective stage. Person will experiment to find the approach that they feel is most beneficial for them. So recovery testing, quote unquote. And then you have your consolidation stage. In this stage, the user has found a way, an effective way to utilize their meds, um, and they're reluctant to consider any changes. And so, how can the model of concordance be used with these types of clients? I want you to think about that because you're going to encounter these types of people in your practice. And think about how you can partner with, work with patients, clients who will have these types of behaviors, medicine taking behaviors. I frequently have patients, not frequently, but I do have clients who, for whatever reason, will stop their medication or not take their medication. They'll come back to me and then they'll be like, I'm so sorry, I didn't take my medication. and um, I didn't like how it was making me feel, or I'm doing this. I had just recently someone shared with me that she was, taking it every other day because that made her feel better. And you know what? I tried to work with her and say, hey, if that's working for you, you're not suicidal, you're feeling okay, then that's okay. Let's try that. So again, finding ways to work with your clients is so important. Then we have your assessing health beliefs here. Um, when you're looking at this, what does it mean to have this diagnosis? For many patients, I had a patient, again, client, this just recently, um, who did not like the fact that she has a diagnosis of schizophrenia on her paranoid schizophrenia. In fact, well, we don't use that much, but anymore. But who had the diagnosis of of schizophrenia on her chart. Um, she wanted me to take that off, and we had a long talk about that and what that meant, um, and what that meant to her, and why that bothered her. And then, what are their thoughts about taking medication for a psychiatric disorder? This again, she was like, "Am I going to have to take these medications for the rest of my life?" And I had to basically tell her, "Yes, it's just like having high blood pressure, diabetes. You're on these medications to help you, um, not to punish you." And then, how do we support, or how do the people around you support or hinder your recovery? I had a talk with her about that too. Her daughter has been very involved, been very supportive, um, and that's been helpful. But if she didn't have that, I don't know where she'd be. So you want to incorporate knowledge into practice. So stay informed, critique the literature, examine your own beliefs, become the apprentice in your clients' lives and behaviors. And in summary, work with the client, and you will have the best outcomes. I guarantee you. So we're going to have a brief review here of psychopharmacology. That's in chapter 5. We're going to look at neuronal transmission. So neurons secrete neurotransmitters into the synaptic gap. The postsynaptic neuron receives the neurotransmitter on specific receptors. And then neuronal transmission is the goal is to modify the neurotransmitter and either enhance or inhibit it. And there's over 100 neurotransmitters. I'm sure you guys remember. You have serotonin, dopamine, norepinephrine, GABA, glutamate, and acetylcholine. Let's look at some basic classes of psychotropic drugs. You have your antipsychotics, there's your typical and atypical, your antidepressants, um, your anxiolytics, mood stabilizers, and ADHD meds, although they're not covered in this chapter. Um, so your atypical or second generation antipsychotics, the main difference between atypicals and typicals is the additional effect of serotonin antagonism. And primarily they work through D2 blockade. Very important to know that. Um, and consider that there's several different types of formulations, frequency of dosing, etc. So you have your long-acting injectables, or LAIs, Haldol, flufenazine, olanzapine, aripiprazole, or Abilify, risperidone, paliperidone, or Invega, which I use a lot. Um, there's also um, Prolactin and others that aren't on here. One other maybe that isn't on here. And then you have your dailies versus BID, or maybe even 3 times a day dosing, which can be very difficult for clients. And then you have your decreased incidence of extrapyramidal side effects, though not absent with second generation antipsychotics. There is a decreased incidence of extrapyramidal side effects, though again, as I shared, it's not completely absent. Um, there was a KD trials that looked at the best medications for using these anti-atypicals, founded by the National Institutes of Mental Health. The typicals or first generation and atypicals are seemingly similar in clinical trials and clinical effect. Um, though atypicals remain the standard of care for numerous practical reasons. So, why do people stop taking their antipsychotics? Well, this patient I was just talking about, she's older, on a fixed income, and is on Medicare. Uh, she's on Abilify or aripiprazole and was paying almost $50 a month for it. I did not know that for a long time, and she seemed to not be doing well always. And I finally asked her, what's going on with your medication? She goes, well, Dr. Spencer, she calls me Dr. Spencer. Uh, it's almost $50 a month. I can't always afford that. I was stunned. Uh, and so I said, well, let's look at GoodRx. And she had never heard of that. So I pulled it up for her and gave her a card. It's $3.45 with GoodRx. Um, so she's been able to get her medication, been able to afford it, is doing well, hasn't had any setbacks. Um, and we're talking about someone who believed people were following her and the people that lived above her were coming into her home, and she hasn't reported any of those symptoms to me for months now. So it's just interesting. You always want to assess for cost. Lack of insight, which you'll learn about, that's agnosia. You'll learn about in one of your lectures this week. The sedation effects from some of these medications it's real. People say they feel tired, they feel like a zombie. Metabolic syndrome, especially weight gain, can be a real problem for people. With antidepressants, there's multiple disease models that potentially explain depression. Be mindful of what meds don't treat. They don't treat personality disorders. They don't treat grief. They can take 2 to 8 weeks to reach a consistent effect. I always try to tell my clients that. There are sexual side effects that's very common um, and can be very troubling, especially for younger people. Um, there's reports that it can be up to 60% of SSRIs um, can induce some type of sexual dysfunction. That's usually because the inhibition of dopamine, known as the pleasure neurotransmitter, by serotonin in the mesolimbic pathway contributes to change in sexual function. And that can be, like I said, troubling for people. Um, Decreased libido. Um, is it so? You kind of have to wonder, is it truly a side effect or an unintended effect? And then there's also the FDA black box warning for children and teens up to 24. There's been a lot of controversy around that FDA warning, um, whether that caused more suicidal events for teens not getting their medication or not. But I did some research on this, and clinical trials have shown that the black box warning is firmly rooted in solid data, whereas attempts to claim that the warning caused harm are based on weakness. So, something to be aware of. That there is the potential for increased suicidality for children and teens in these medications. You always want to warn them about that. You have your treatment protocols, which I have posted a nice access to evidence-based guidelines for psychiatric mental health treatment guidelines. You have your STAR-D and your CANMET and others. So for someone with depression, you have phase one SSRI, I'm sorry, of choice. Uh, Remember, you want to start low, go slow, but you also want to get to the maximum dose before switching to another SSRI. Um, so, for instance, if you're starting, say Lexapro at 5 milligrams, max dose is 20. You want to get that patient or client to that dose before, stopping it, unless they're having some serious side effects to it. But if they're saying they're not getting relief, they're not improving, obviously, if they're only on 5 milligrams, yeah, you really want to push that up and see how they do. Again, barring any side effects. Phase two is a second SSRI or switch to another antidepressant. Um, these could include SNRIs, bupropion, mirtazapine, TCAs, and even MAOIs, even though those aren't much used anymore. And then phase three, you can augment with a mood stabilizer, lithium. Phase four, consider other options such as um, TMS and ECT. And always consider your diagnosis. And then again, this pro here, integrate therapy at every step. I always tell my clients that medications are only so good and only do so much. Therapy is very, very important. Even for your schizophrenia patients, therapy is essential. Learning how to retrain the brain and the mind and their thoughts. Okay, anxiolytics, the bane of my existence. I want to caution all of you to to prescribe these judiciously. Be very careful. Do not get into the habit of giving these long term. There is a place for them, and don't be afraid to use them short term. And by short term, I mean less than 2 weeks. Um, but there are clients, patients out there who will, think they need their Xanax twice a day, every day. Um, that is not correct. We have to work on getting patients off of those. They are highly addictive, not first line treatment in psychiatry. And there's other options. You have your Buspar, clonidine, gabapentin. It works great. I use Buspar a lot, Buspirone. Um, so just remember that, and you want to not stop your clients right away on an anxiolytic. You have to wean them off of that because it can cause seizures and death. So you may inherit a patient or get someone who's on Klonopin, 1 milligram twice a day. Uh, you're going to have to work with them to start to wean off of that. But again, there is a place for them short term. So don't be afraid to use them. But I always tell my clients, I'm going to give you this, but it's only going to be 2 weeks. And after this, that's it. We'll have to revisit this in maybe another time, but it's not for daily use. You have your mood stabilizers. And what is a mood stabilizer? Well, like the name says, they help to stabilize the mood. So lithium is a gold standard, but it is difficult to manage. Lots of lab work. You have to be careful with other medications, uh, but it is indicated for bipolar 1 and is a great mood stabilizer. It does decrease the risk of suicidality. You also have your anticonvulsants, such as valproic acid, Depakote, carbamazepine, Trileptal, lamotrigine, Lamictal. And then your atypical antipsychotics are also indicated as a mood stabilizer in bipolar 1 disorder. You have quetiapine, Latuda, aripiprazole, Abilify. So in summary, know your main classes of medication. There is no one size fits all. You do want to follow guidelines as best possible. And then remember, like I shared, meds are not the only answer. Please, please, please you need to, when you get done, or even you probably don't have time in school, take some courses on therapy. Learn how to integrate it into your practice while you're working with clients. There's some brief, short-term therapeutic things you can do while you're working with people. Have a therapist that you like, or that you know that you can refer people to. Um, Again, meds aren't the only answer. Psychoeducation, giving patients education, YouTube videos. There's all kinds of stuff out there that you can give to your clients. So that's the end for this week. Next week, we're going to be looking at anxiety disorders. So we'll look at generalized anxiety disorder, panic disorders, OCD, PTSD, and we're going to review some neuropathophysiology. There is group discussion boards starting next week. You'll want to pay attention to what groups you're in, and then when you make those discussion initial posts. And then there'll be a quiz next week over weeks 1 and 2. And you will have 3 attempts to get your best score on a quiz. All right. Thank you. And I wish you guys a great week.